all and thank Irene Aguilar for her effort as Vice President of Healthcare for All Colorado and Chair of our Denver Chapter. And thank you to Senator Irene Aguilar for giving her life to providing care to those who need care and fighting to secure healthcare for all Coloradans. While we may not have exactly the same paths to achieving healthcare as a right, I have no doubt that all of us are committed to securing a universal system that leaves no one out. I am sorry I cannot be with you today. I am recuperating with in-home nursing care following a GL bleed and a bloodstream infection with MRSA that caused septic pulmonary embolism and surgical removal of an arm vein from my wrist to my shoulder. One of the most distressing parts of the past few weeks has been when I was asked to pay my $250 ER copay while on a gurney in the ER treatment area, fever raging, and doctors beginning the work up for my life-threatening infection. It is disgusting that business office personnel are allowed access to patients to ask about deductibles and copays at such moments. And achieving a healthcare reform that ends those abuses forever is critical to me. I haven't yet had the opportunity to fully review the bill Representative Janelle is putting forward in the Colorado House that was drafted through the Cooperate Colorado folks, and that is Senator Aguilar's bill. I've been too ill, so I will look forward to hearing from the HCAC Legislative Committee about the House version of the bill. We'll get the chance to consider the organizational position on this bill, just as we have other health-related bills this year. Rest assured, we will consider the bill carefully and fairly. Finally, I will hope you all join me in dedicating our efforts to transforming Colorado's healthcare system into one that values life and health over profits and wealth. We simply cannot lay claim to living in a humane society unless and until we fix this horrible profit for business-driven system. No one should do as I have done the past few weeks, as I worried that living with serious illness would cost too much and that death would serve my family from another financial crisis driven by health crisis. My health should have come first. Instead, I worried about the cost. Again, thanks again for being a part of the caring community that wants to heal this mess. Mark your calendars now for Medicare's 50th anniversary celebration on Thursday, July 30th. We can and must preserve and protect, improve and expand Medicare. Have a great meeting. Donna Smith, Executive Director. So, I'd like to introduce Senator Irene Aguilar, but I know she needs no introduction. We all know about Senator Aguilar's work and her fight to bring universal health system to Colorado, as well as other bills and efforts she's had to find areas where we really need to shore up, issues that would help doctors and hospitals provide better services to our community. And I welcome Senator Irene Aguilar. Thank you for being here.
I looked around this room and realized I knew almost everybody. I think there are 4 people whose name I could not state off the top of my head. So rather than divulge who they are, if you would quickly tell me your name, I'd appreciate it. We'll start with that.
Omar Villanueva Ruiz.
Patty Sullivan.
Michelle Swenson.
Barb Watson.
Judy Burke.
Vince Markovchik.
Steve Bailey.
What was your name, sir?
Steve.
Steve.
Nate Wilkes.
Judy Pius.
Allison Greenson.
Alan Cooper.
Lydia Guzman.
Ken Connell.
Rob Carlson.
Eleanor Christensen.
So Eleanor is my mentor, if any of you don't know that. People often ask me how did I come to be a state senator, and I said I had the misfortune of finding out how healthcare was financed in the United States, and it pissed me off. And the good news is it still pisses me off, so that keeps me going day by day. But I met Eleanor back, so I have a daughter who's developmentally disabled, and I served on the Colorado Developmental Disabilities Council. And while I was on that council, the 208 Commission on Healthcare Reform was formed, and the commissioners were picking plans and evaluating them And they wanted to select 4 subcommittees to look at the plans from different perspectives than they might as commissioners. And there was a provider one, a business one, a rural one, and one for vulnerable populations. Now, Nathan, were you on the business one?
business one.
He was on the business subcommittee, and I was on the vulnerable populations subcommittee. I applied as the mother of a child with disabilities, somehow forgetting that probably the fact that I worked at Denver Health for 20 years and was Hispanic and a woman made me qualified as well, but I applied because of my daughter who is disabled. And we had a chance to look at the 4 plans that the commission had chosen for evaluation. And then when they drew their own plan up, the 5th proposal, we got to look at that as well. And we were asked to look at these plans and talk about what the impact of these plans would be on the population that we represented. And as many of you know, one of those plans was submitted by Eleanor and, oh gosh, Dr. Rocky White. I was gonna say Rocky Ford because of the candle. Right. And Healthcare for All Colorado, and was Medicare for All, essentially. And so even though I'd worked at Denver Health forever as a doctor, one of the nice things about working at Denver Health is every 2 weeks there's a paycheck in your account. And you have no idea what's happened to get that paycheck into your account. And every 2 weeks, no matter who you see, how they get paid, whether they pay it off, you get that same paycheck. So you're really sheltered from what's happening in the real world, if you will, around healthcare. And so when I was part of this task force, as Eleanor knows, and so often happens when you're a doctor, it's hard for you not to take charge. So I ended up being the co-chair of the task force. And we started out trying to define who is vulnerable. You know, when we're representing vulnerable populations, who are we talking about? And we had people from different ethnicities and cultural backgrounds around the table. We had homeless folks, a lot of folks representing different medical disabilities, chronic diseases, and veterans. I mean, it was a very diverse population. And as we sort of said, okay, what do we have in common being vulnerable populations? It was interesting because at the end of the day, we decided that everybody in the United States was vulnerable. Because right now, your health insurance is tied to employment. And if you have the misfortune of walking across the street and getting hit by a bus, and you become unable to work, you use up your 90 days FMLA if you're lucky enough to have a job that offers that, and you lose your job, you lose your insurance. Now you can purchase it, right, if you can afford it, but most of the time you can't. The good news is that I do think that for people who are citizens of the U.S., the Affordable Care Act has changed that because you would then become eligible for Medicaid, and that was not the case before. You would pretty much, if you were unable to work, become eligible for Medicaid, because Medicaid is no longer asset tested. So you can own a home and own a car, but if you have no income, you're eligible for Medicaid. And if your income, you have some income, but it's below 400% of the federal poverty level, you're eligible to purchase a plan with a tax credit on the exchange. Unfortunately, as many of you know, and as Donna's story illustrated, that doesn't shelter you from all the costs, and there are still people asking for you to make your co-payment and contribution after really you've struggled to even purchase that plan. So unfortunately, we created a mandate to purchase under insurance, I think, in our country at some level. And we haven't fixed the fundamental problem, which is what are driving the costs at the back end, including, I think, profit-driven healthcare. And one of the things that's been sad to me in the legislature is that really there are a whole group of people who really think that innovation will only happen if you make money from it, which I think really undermines the ethics of most people who choose to go into science and medicine. I don't think that most people go into research and science thinking they're going to innovate to make their millions, you know. And I think that there are lots of other things that drive change and innovation and things like that. Finally, I think that you can still be paid well for those, but there's a difference between being paid well and raping people. And so that's sort of one of the first fundamental differences I think you see in legislators, are there truly folks who think that if you take away the financial incentive, nothing will happen. And as a physician who has worked with many ethical physicians, who, and I can't even name physicians who I don't think would be ethical. I mean, I know there are some who exist out there who really are trying to find a way to make a big buck, but most physicians really do enter the field to make a difference and help people. I know 1,000% that's true for nurses, because they certainly don't make the big bucks, you know? So it's not, as scientists, of course, never expect to make big bucks, and they're lucky when they run into something exciting, so, and they're very thrilled of what they've contributed. Anyway, so I do think that at the end of the day, we need to hope that we continue to be a society where people do things just because it's interesting and stimulating and for the public good, and not just for the hopes that they could become one of the 0.1% above everybody else. Not that they shouldn't be paid well for what they do. And I truly believe that, or I wouldn't keep moving forward with this idea of how do we make a healthcare system that, as Eleanor described, is both fiscally responsible and socially just, because I think it's possible to do both. So anyway, after that commission, Eleanor came up to me when they were at one point and introduced herself to me and invited me to an HCAC meeting, because she could tell how much I loved the HCAC plan. And I came and joined HCAC, and I got talked into at some point being vice president, and then for some reason the president had to resign, and suddenly I found myself being the president of HCAC. And during that time, we worked to get a bill introduced in 2009 that represented at the time John Cafalas. He's now Senator John Cafalas, and I sit next to him on the floor of the Senate, which is fun. Introduced to sort of get a group or task force together to say, how could we really make universal health care reality in the state of Colorado? And all the big players in healthcare ignored us. So one of the funny stories I always tell is I actually sat down with the governor's health policy assistant, and I'll just call her CB, I won't disclose her name. And I got her finally to meet with me at Panera's, and we're sitting there, and she's literally looking at her phone the whole time saying, Well, she now sits across the desk from me asking for my support on bills, so that's sort of fun. Anyway, but all of the people like from CCHI and CCLP and all the health things, they really thought we were gonna go nowhere, so we were ignored. And then when we made it out of our first committee, Business, Labor, and Technology, they started paying a little bit of attention. When we made it out of appropriations, everybody was awake. And by the time we passed second reading on the floor of the House, the governor had woken up, and he successfully lobbied for Democrats not to vote for our bill, and it died. Never got to third reading, but that was pretty historic. That was 2009. And in 2010, as you may remember, that was when the Affordable Care Act was being discussed. And nobody wanted to talk about health care reform at the state level because there was so much fire around the Affordable Care Act. And so we really could get no one interested in sponsoring a bill for us. And on behalf of, I think, HCAC, at the end of the year, I was speaking at PNHP because they were in Colorado that year, and talked about how we couldn't get anyone to run a bill, and we were just going to start studying the exchange and figuring out what things could Colorado do to make the exchange work better for people who were here, so that we kept being part of the discussions. And this woman, Jen Gross, who's one of my constituents, came up to me and said, hey, you know, my senator's resigning, and I am a precinct committee person, and I get to pick his replacement. So maybe we could bring this up as something for a discussion, and the replacement would run a bill for us on universal health care. And I said, that's a great idea. Who's your senator? And she said, Chris Romer. I said, wait, he's my senator. Could I run for that seat? Because I truly had no idea what you needed to do to run for office. And she said, I think so. So I called my friend Susan Lontine, who had encouraged me to go to the Colorado Institute for Leadership Training after that legislative experience, which I had done, and said, Susan, could I run for this seat? She said, you could, and I bet you could win, and I'll help you. I only told you her name because she is now a representative in the House of Representatives, representing House District 1. She was my aide for 2 years, and then she ran for the seat and is now in the House of Representatives. And so some people wonder why Susan does everything I suggest. Well, now you know. Because we started out like this from the beginning. And so she helped me, and she was smart enough to say, you know, there's this woman named Fran Coleman who is a representative from here who's thinking about running. She has a lot of connections, if you could get her to support your race, that would make it much easier for you. And some of me telling you these stories is to tell you that really a lot of things happen because of relationships and asking questions and finding out how things work. And so I met Fran Coleman, and Fran Coleman really liked me. Her name is Fran Aguilar Coleman. So she really loved who I was and what I represented and what my values were, and said, I was thinking of running for this race, but now that I know you're in it, I won't, and I will help you. And so that all happened in November and December 2010, and in January 2011, I took my oath of office and introduced that year a bill for a universal health care system, to have sort of the same bill we did in 2009, to have sort of a group set up to study and figure out how we could implement it. And that was what I learned about politics. Because what I learned was that the party line was that we needed the Affordable Care Act to be implemented in Colorado, and what I was trying to do was a distraction, and perhaps potentially disruptive to getting the Affordable Care Act implemented. And the chairperson of the health committee basically said, I won't support your bill and I don't want to hear it in my committee. And thankfully she said that to me early enough that I spoke to the Senate president, who was a supporter of universal health care, and asked if he could be assigned to the Business, Labor, and Technology Committee instead, which is what happened with it. But then during our caucus meetings, because you meet as a group of Dems on a regular basis, it continued to be a point of contention, and she really did not want my bill brought forward at all, but at a minimum, she didn't want it brought forward until the ACA implementation of the health exchange bill had passed. Now, I don't know how many of you remember this way back in 2011, but the health exchange bill had both Senator Betty Boyd and Representative Amy Stevens on it, who is a Republican. And so I thought naively, well, it's bipartisan, it's going to pass pretty quickly, that's an okay thing, I'll agree to that. And so I said, okay, let my bill go in, but we don't have to hear it until your bill is passed out of the Senate. Well, that was when Amy Kerr exploded and Representative Stevens got raked over the coals by her party, actually a primary that year for her seat, and her bill literally passed the weekend before the end of the session, or close to that. So my bill didn't get heard until the day before the session ended on the floor of the Senate. And I didn't know all the games that you could play on the floor of the Senate at the time. I was just going to discuss it and then lay it over until after the session ended, because I knew it was going nowhere. But there's this thing you can do where you yell division, and everybody has to vote right then and there. And I was really pleased because all of my caucus stood up and voted for the bill. And so it passed, but then we ran something called a committee of the whole amendment that said it didn't pass, because one of the things you learn in politics is if you do something, even if it doesn't work, it's used against you in your campaigns, right? So they wanted to take that off the record so these people wouldn't be labeled as, social commies. And the other thing you learn in politics is that nothing exciting happens in the legislative session when there's an election year, because nobody wants to have something exciting happen that people aren't going to love and have it used against them in an election. So in 2012, I couldn't get support to introduce my bill again. In 2013, I did. Again, at that time we held it in the health committee. I was chair, Senator Jeannie Nicholson was vice chair, and so she presided. We had a great discussion. It passed out of health. It was clear to me it wasn't going to get 2/3 on the floor of the Senate. And I worked really hard to try and get some Republicans to understand the fiscally conservative aspect of it. And really found out how high that ideological divide is. It doesn't matter if you're going to save lives, doesn't matter if you're going to save money, doesn't matter if all the people who make lots of money can still make lots of money. That's government. That's government running healthcare. Even if it's a separately elected board of directors, that's still government takeover of healthcare. And just could not get past that ideological divide. And I only tell you that because Representative Janelle and I are not naive. We don't expect that our constitutional amendment work she's introducing this time, and we had her do it in the House because at least there's a Democratic majority in the House, so at least it could get out of committee. Probably with a promise that it won't come to the floor. But it becomes a way of doing something you call earned media, right? Where people are writing about it, people are talking about it. And interestingly for me, it becomes, I don't know what to call this, because ultimately the people who don't agree with me have to work with me on a lot of other policies. And they know that I have this golden chalice that I see up here, and that any compromise they offer me is a compromise. Because at the end of the day, this is what I want. And so I think at some level it gives me a little bit of bargaining power to say that's not enough. I know you can do better with credibility because they know that I really understand this subject and that I know they can do better. And so it's been sort of fun. I have a great relationship with the head of the Colorado Hospital Association. Ideologically, we could probably not be more different, but we have a great relationship because there are lots of things that can happen now that he needs my help with. I actually have the head of the National Federation of Independent Business come forward and thank me for trying to explain a health policy to his Republican members and say, you understand this so well. I said, that's why I want a universal health care system, you know, because I understand it very well. So it's been a fun experience. It's been frustrating for me because I really thought that by getting into the legislature, I could make this happen. And I realize now that it's the grassroots that will make this happen. And I was sort of feeling discouraged until I saw what all of you who were part of the GMO effort did last year. That was really exciting to me, to see that people without much money, just by having an idea that people really thought had value to it, could get the support they needed to get the signatures to get on the ballot. And that was very empowering and exciting to me. It showed exactly what we've always feared, is that if we can get onto the ballot and we don't have the money for the campaign, it's not enough. We also need the money to run the advertising campaign, because I didn't know about you, but they lost because the industry put in, was it $10 million to $20 million to 600,000? And I can't imagine what that number would be in healthcare that would come out to fight a ballot initiative in this manner. And so so going full circle on back to what Eleanor wanted us to do 6 years ago, which is go all around the state and talk to people and answer all their questions and get their support and buy-in, understanding that there's going to be a huge media effort if we're successful enough to get all the signatures at someday that we can to get onto the ballot. But it's going to be the people who are going to make the difference. And as we see corporate America do more and more things where they deceive the people, it helps us. It helps our credibility going forward, I think, because people realize that money doesn't necessarily talk for them. So that was my quick history of Irene in the legislature and what I've learned in the last 5 years. Do I have any regrets? No, because it's all information, right? Everything you learn is information. Made a lot of contacts. The one thing I can tell you I have learned though is that the day I lose my seat, those contacts go away. Unless I can keep myself in some position that has some kind of authority. The person who was chair of the Senate Health and Human Services Committee looked for 2 years for a job and nobody would give it to her. Because once you're not elected, you don't have a vote, you're not important to them anymore. And so I have 3 more years to make a difference. And during that time to hopefully find a different position I could take that will allow my voice to still carry weight. So right now I'm eyeing being the Commissioner of Insurance in 4 years. We'll see what happens. Just need a good Democratic governor. And, you know, I already told Lieutenant Governor Garcia that if he runs, I want to be his Commissioner of Insurance. So we'll see. Anyway, so what's happening now? So as you know, I watched with you the Supreme Court battle over the Affordable Care Act, and when it was clear that Medicaid was going to become an option, I literally wrote to the entire Democratic House and Senate caucus and said, I'm putting in a bill title, I want to run the bill to expand Medicaid. And was happy to do that. We didn't win because I ran that bill. People will say, oh, Senator Aguilar ran the bill to expand Medicaid. We won because the Hospitals Association knew that their future was bleak if we did not have Medicaid expansion. And the Hospital Association actually has a very loud voice. And the Pharmaceutical Association had that same benefit from Medicaid expansion, right? There was less pressure on them because people who needed medications could get them through Medicaid, and even though it didn't pay as much as private, it was better than getting pressure to give for free medication to people who didn't have anything. And so the University of Denver, I don't know who paid for the study, but did a study that showed what the economic impact of Medicaid expansion would be on our state, and it was wonderful. And so I also now serve on the board of Denver Health and Hospitals. The way that happened is that the Latino community felt like Denver Health didn't have any people who really represented the community and really lobbied and pushed very hard to get me on that board. And Denver Health went from running in the red to running in the green because of Medicaid expansion. And in fact, the city and county of Denver has a 94% insurance rate. Most of that increase now is from Medicaid expansion. And so Medicaid expansion has had a great effect. And I always tell people, I hated the Affordable Care Act until I spent a month in the legislature, and then I thought, how did Obama ever get that through? So I think Medicaid expansion was a wonderful thing that they were able to pass at the federal level, and I feel really sorry for poor people living in those 23, 25, 26, I've lost the number of states, who still refuse to take the money and do Medicaid expansion. They're all playing games around, well, if you let me do this with Medicaid money, I'll do it, because they know at the end of the day that it's harming their state, it's harming their hospitals, it's harming, and those are probably more important to them, but it's also harming their people living in the
I don't care about the people.
And so, exactly. It's the states, the hospitals, oh yeah, and then those people are being hurt too. And I also ran the bill to align our laws with the Affordable Care Act laws, the ones that got rid of discrimination for pre-existing illnesses and other things. Although it was a really big, long, technical bill, so I couldn't really tell you everything that was in there, and learned that there was probably a few things that shouldn't have been in there if I'd had the time to really read through and understand all of the issues, but we're fixing those now. One had to do with autism and having somewhat of a limit on autism treatment. Senator Cafalas ran a bill this year to fix that. So as we identify problems, we're working on fixing them. The business community still completely supports both Medicaid expansion and our implementation of the Affordable Care Act, because as business owners, they realize that this is the only way to ensure that many of their employees can get access to health insurance. And in spite of all the rhetoric, overall, we're not seeing costs increase. I think that we are seeing the problems we would have anticipated from underinsurance, which is that people, I think some of the costs not increasing is all they can really afford to get is prevention. Once you need the other stuff, it's still really expensive. One of the squeaky wheels that has come out of the Affordable Care Act is this whole issue of specialty drugs. And so specialty drugs are the new biologic drugs. And they're things like, my sister has rheumatoid arthritis, and they have injectable anti-tumor necrosis factor inhibitors. And I just say that so it sounds expensive, which it is. She has been on this for 10 years, and it's $1,800 a month for her medication. And it's been that much the whole 10 years.
Yeah.
And then there are drugs that are outrageously expensive like that for multiple sclerosis. And there are drugs that are outrageously expensive like that, if you all probably read Stephen Brill's article, for cancer treatments. And so what's interesting is that the design of health insurance plans is such that patients are being asked to pay more and more toward the cost of those drugs. And so the federal government has realized that this has become a de facto way of discriminating against people with expensive diseases. Because if none of your plans provide adequate coverage for their expensive drugs, they're going to pick the other guy's plans. And so our Commissioner of Insurance tried to intervene in this by saying, look, you have to make it that they pay the same amount every month. They can't have to pay their $5,000 co-insurance the first month for the drug. And I actually oppose that. And the reason why is that the voice that's being heard right now is that of these consumers of chronic diseases. If we pull them out of this, if we protect them, there is nothing putting a cap on pharmaceutical prices. And nothing keeping pressure on the pharmaceutical companies to keep their prices down. And so I've talked to the commissioner, and we're supposed to keep talking over the interim about, can we have sort of a little Cover Colorado reinsurance fund for people who need expensive medications that still doesn't put the pressure on the pharmaceutical industry unless we tie that fund to taxing pharmaceutical companies and pharmacy transactions. So we're looking at how else might we address that, because it is an issue. for people who have that chronic disease, and this is sort of one of the things that has come out. The other is that because there's still so much talk about repealing the Affordable Care Act, we are not getting the signups on these change we should be seeing. There's still people just ignoring the mandate and saying, I'm just gonna pay the penalty. And I know this year was $95 for an individual, or, do you know the percentage of income?
It's 2% now this year,
And then what does it go up to?
2.5.
And how long does it take till it gets to something significant?
Well, 2.5% of your whatever your total income.
And that's it, it never goes higher?
No.
No. And see, if you don't make much money, 2.5% is cheaper than your insurance plan. And so the issue, and Nathan has probably talked with you about that we're seeing is that people are just choosing not to buy insurance on the exchange. And unfortunately, we've had issues because the Fed said you have to first be denied for Medicaid before you can get an advanced premium tax credit. And that's been a nightmare to people going on the exchange, being denied for trying to get that denial and get onto the exchange plan. And also, a lot of people have found out, in fact, they qualify for Medicaid and they really don't want to be on Medicaid. And there's no other option for them. And so.
There is an option, you forfeit every penny of your subsidy.
Right.
Which is what we do.
So I wonder though, after thinking about that now, and Nathan, you might know this better, could they be on Rocky Mountain Health Plans or Kaiser with Medicaid? Do you know?
They'd be, well, I know that those cover the Medicaid population, right, so.
Because what I wonder, so that's still been an issue, and then people going off and on Medicaid, so the churn has still been an issue. And those are two things I'm hopeful going forward we can continue to try and address. I have a law student interested in health policy who's written a paper for me about what we might be able to do about churn.
Someday we'll run out of money and we'll shut up and take the free insurance, but we're not there yet.
Yeah.
Oh, Dave, why are you doing that, can I ask?
I don't trust Medicaid, I don't want free insurance, I believe that you get what you pay for, and I don't trust the whole process. And I never wanted free insurance.
Community health centers are good places.
I
Dr. Health would love your Medicaid business.
the only thing that really got my gut, I would have been just fine with no subsidy. The thing that upsets me is my taxes go to subsidize people that make 4 times more than we do. That's what got my gut, my gall, if you will.
So I think that's something we need to look at addressing in the future for folks who want us to.
Irene, I recently read that Washington is permitting some states to essentially privatize Medicaid, give vouchers, or, and there's this effort to privatize Medicare, of course, and I got notice from an insurance company, I'm sure, telling me that Medicare is going to be, privatized and my costs are going to go up very soon. So I wonder what you think, how we can, deal with this issue.
So, my thought there was that I never trust privatizing something because I think just like with specialty drugs, there's always a way to get yourself the healthy people and the sick people, the part that the government still has to pay for.
Oh, I think it's just a way to
it's
get
another
rid of
meaning.
Medicare and Medicaid.
Right, but if you were to do that and you could only buy these plans that also offered private insurance, so Rocky Mountain and Kaiser both do both private insurance and Medicaid. Colorado Access does both private insurance and Medicaid. United doesn't do Medicaid. So if we were to do it in some way where you could only have one of those plans that does both Medicaid and private insurance, I would be open to considering that, because at least if we're benefiting someone, it's someone who also takes Medicaid. It's not just someone who's just taking private insurance. But I don't know how you design that and if that's possible. And I'd only do that because I've met a number of people like Dave, who, maybe my income puts me there, but I have enough assets and other things and my income's not always there and I really don't want to be on Medicaid. But it's,
But they're killing off public, this is how they're killing off public programs like Medicare and Medicaid, essentially. They want to privatize. This is where the Republicans and the neoliberal Democrats are pushing us in Washington,
Yeah, no, and I understand what you're saying. I'm just trying to figure out a way that we could do that in a way that benefits those private insurers who are treating them just like they treat their private clients. Because that's what I want. I just don't want it to be that you're my stepsister, but you have my name on your card. But if you're just the same as the other people and you have my name on your card, and maybe that Medicaid dollar will help them keep their rates lower for their non-Medicaid patients, because now it's subsidizing that instead. I don't know, and I don't know if there's a way to do it. we have to get a real health economist to sort of look at that, and tell me how it could be gamed. Because I know if there's a way to game it, someone will find it.
Well, see, I think in Washington, the Republicans are pushing really hard for really bad ideas, but they push so hard that they get there. And the Democrats aren't making the best case for healthcare reform, you know what I mean? They're not telling us
They're
what
still
the best
running away
case
and
is.
hiding from even the Affordable Care Act, which is too bad.
Could you speak to hospital-based insurance? I've just heard about that, you know, hospital systems going into, is that it seemed like that could be a real option potentially, and I think Denver Health would elevate, is that
Yeah.
the same?
So it's sort of like Kaiser, if Kaiser owned a hospital.
Mm-hmm.
They do in California.
Yeah, and it's building up on that accountable care organization model to try and align incentives, where the hospital's incentives and the outpatient providers' incentives and the insurer's incentives are all the same, which is to control costs. And so, again, in theory, I think it's a good theory. It certainly, to be honest, is part of the theory on which the Colorado Care Plan that I'm discussing and our initiative is based on, is how can you align incentives to be focused on healthy consumers. To have that right now where we still have a for-profit hospital, medical system worries me a little bit, because if they do a great job, that money just goes into their profits, it doesn't go back to the consumers, and that's sort of the biggest difference between that idea and corporate cloud or Colorado Care, as we're calling it now. Our program would have the same thing, but the funds would all still stay in a fund for the consumers, and would need to be used to benefit the people who paid them. So that's my only concern with that. I know university is looking at that, and Centura at some level is building themselves up to be in a partnership with United to do that. Patty?
I have a couple of questions. One, I think I've asked the email group maybe before about it, but like, I know somebody who would qualify for Medicaid as far as income, but she owns $350,000 homes, you know what I mean? And so she won't take Medicaid because there's a provision in Medicaid that if you take Medicaid, then later on, the house will be the state's house, it won't be her house or something like this. So I had a question about that.
Yeah, I asked Medicaid about that because one of my constituents owns a business, and she was concerned about the same thing. She doesn't make much money, but she has this asset. And I was told, no, they do not do assets in this. Long-term care, they do, but this kind of medical Medicaid, they don't. So if you went into it because you needed it to pay for a nursing home and for home care, that kind of Medicaid does take your benefits. Use it just for health insurance, it's not subject to that. There's a different kind of Medicaid program you go into when you need long-term care.
So if it's just for regular
Medicaid is not an issue.
medical, then you're fine.
Right. But if you apply specifically for long-term care Medicaid, then you are at risk for having it happen.
Okay, well, I think she's misinformed about that.
Yeah.
So,
And
okay.
if you email me, Pat, I can send you the email I got from my constituent that I sent her from the Medicaid office itself on that issue. Shelley?
Yeah, I just a quick question, I was when you were talking about some of the Medicaid and chronic illnesses, and I don't know if it's feasible within the state, I just kind of had this idea come to mind, that maybe, would there be a way to get Medicaid expanded for people with chronic illnesses? I mean, we want Medicare for all, but if we call it Medicaid for all, we really care. And you know, Marcia Angel is the one who said, we should just keep getting another decade into Medicare, and that's how we're gonna solve this problem. So maybe we have to work from the bottom up, Medicaid, and whittle away from the bottom up. And I wondered if there's some kind of bill, even statewide, that could start to work on this while we're working for something that's more universal. Like, could you pass something legislatively that would include everybody with chronic illnesses into Medicaid, and then you wouldn't have to go through all this,
Yeah.
nitpicking?
You know, it's interesting you say that because, and I don't remember if you remember this group, there was a South Metro Denver Chamber of Commerce who was running a bill around redesigning healthcare at the same time we were running our bill. And they had Representative Joe Rice at the time. And he supported both of us, because he just wanted us to figure out a different way to do healthcare. I bring them up because at some level, as we talked further and met together, their idea was similar to yours. Their idea was that Medicaid be a safety net for people in poverty and people with chronic disease. And that all the other things be in either pure out-of-pocket or private insurance. And then once you had one of those horrible diseases that cost you millions of dollars, you got into the state program. So
Well, I
it's
thought you were before.
interesting.
I mean, when I.
Yeah, no, but I just meant,
Sort of as a
so you
front,
could be in that market and then you get breast cancer, let's say, and you need a
Yeah.
transplant or something, then you get transferred into that market, into the state program as a safety. But, or you get put into the, by the nature of your diagnoses. There would be certain diagnoses on which you would be eligible immediately for the state plan.
Yeah, well, because I'm looking at work globally and figuring that
Yeah.
life is a chronic disease. We really look at it. Once you get it, you know, it's like, life is a terminal event. So you're going to have something, so pretty much, if you finagle it right, probably everybody would eventually be in there, and you eventually would have Medicaid for all, and get over yourselves,
Right.
you know? Because with a lot of these people, because they're so narrow-minded, tunnel vision, with the way they look at medicine and humanity, they're just gonna keep saying they're part of the line.
Because actually a number of the people in the South Metro Denver Chamber of Commerce folks were Mormon.
Yeah.
And they actually do have a sense of, you know, I need to take care of my fellow man if they can't take care of themselves. And so
think
that
that's
was
true
part
for
of
most
what they got.
religions.
So I don't know if I
But
have
said
any
other
other.
Mormons, because
Yeah.
when I've been Catholic, that's what they told me,
Yeah.
is that they're concerned, but only about other Mormons.
Oh,
They will-
Well, these guys, I think, were also concerned about how much it was costing them as business owners. You know, so, so it allowed them to expand their Mormon principle onto the rest of the population.
I'd like to ask you a question about cost containment. In your proposal that's going to be coming up, how are you going to do cost containment for hospitals without a global budget? Isn't a global budget vital to cost containment?
So it's interesting, hospitals are a creature in evolution. And I say that because I just read something from an American Hospital Association magazine where someone in their think tank was talking about how hospitals really maybe just need to be an outpost that ships people into a central place for care, which is sort of more similar to what I think a single payer plan envisions, and really more similar to what I envision. And so the way it happens in my model is you've taken on this risk either as a provider or as a system or as a hospital, and this is all the money you have, and you have to figure out how to make it work with that money that you have. So it is a global budget in a different way, in the sense that that's all you have, you don't have more. Now there is extra money sitting out there, because if they all blow it, they're all gonna crash and die, right? And we need certain numbers to be sustainable, and that's what the global budget will support. So the global budget will determine sort of like Medicare determines crisis hospitals. The global budget will ensure that those places survive and everybody else is on their own.
The next question is on the ACO concept. How and who is going to decide how to divide up the pot of money?
So that would be part of the board of directors for the cooperative. And what's stated in the initiative is that you can only, that you need to risk adjust it based on things that can't be cheated. So you and I know that you could say you're a horrible insulin-dependent diabetic and really you need one shot once a week or something, you know what I mean? So things that can't be cheated to me are your age and your educational level. Because usually age and educational level are good surrogates for health status. And so that people who had more patients who were older would get enhanced reimbursements. People who had more people with poor educational levels would get enhanced reimbursements as well. So that would be what the risk adjustment was based on. Yes.
Are you going to talk to us more about the bill that you would?
Yeah, well, I can talk, you know, I don't know how much I can talk about the bill itself because it's long and boring, but I can go over the outline. So I want to tell you one other thing about the bill before we go into it is that As I'm sure you are all aware, Vermont's governor backed away from single-payer health care. And he did it because they had an economic analysis done that showed that was it 19%, it would cost you a 19% tax or something outrageous. So of course, as soon as that happened, we panicked and said, is our economic analysis accurate? So some of what happened, there are a couple of things that were fundamentally different with Vermont than what we're doing in this plan. There are a number of things, but the first and most important one is that Vermont was not going to impose a premium on everybody. They were excluding ERISA plans. Our plan imposes a premium on everybody, whether you have ERISA or not. And then you can choose to say, well, now that we have that, I'm not going to provide an ERISA plan, or you can continue to do an ERISA plan if you want, but you still have to pay the premium. So that's one huge fundamental difference between what Vermont was designing and what we were. The second thing is Vermont grossly overestimated how much they were going to get from the Affordable Care Act. And we have the advantage of being able to work with our legislative council, who can tell us how much we've gotten from the Affordable Care Act, and Connect for Health Colorado can tell us how much we've collected in advanced premium tax credits. And so you will see that the number has gone up. The number we talked about before was 6 and 3. It's now 6.667 and 3.333 or something like that. So it had to go up 1 percentage point because of, based on the real numbers we're getting from Medicaid and Connect for Health, that estimate was more generous than it should have been. And so that's the one big change. And then this document, which is back there, goes through sort of a little bit of the financing and how it will be financed. It must have been that one. This is old stuff. I go around and talk a lot about what we're doing in the legislature. And when I do, I still always bring this up because I think people forget this. You know, I get so tired of hearing people say, I'm healthy, why is my insurance so expensive? And they
saving up for when you're sick.
Exactly. It's because there are other people who are really sick who you're helping to keep alive right now. And I'll usually use people with disabilities as an example, children born with disabilities, because they're pretty much a group that nobody faults. Because I know that my daughter is in at least that top 5% group, if not the top 1%.
Yeah, we're in the top 1%, probably
Yeah.
the top 10th of a percent.
Yeah, I was amazed at what hemophilia drugs cost.
Yeah, he's running about 2.5 million a year now.
And I still always show everybody this. I had the Colorado Health Institute update the screen for 2011. I'll have to do it again for 2013 because we still are way overspending everybody else, and nobody's even approaching us. And people really don't understand that red line. The red line is that's the amount of tax the government gives up by giving tax deductions to corporations for buying insurance for their employees that self-employed people don't get. So here is what the legislation does. First of all, it creates an interim board of directors because somebody has to get started doing this. And they're people chosen by majority and minority in the legislature and the governor. And their job is to work with all the agencies and start the application for the Section 1332 waiver under the Affordable Care Act. And in the course of doing that, they're going to need to coordinate with the providers and systems to figure out, okay, how much money does it have, how much money are we eligible from the feds, and will this system work? We'll have to hire the actuary to do the analysis to say that, yes, this system will be sustainable over at least 10 years at no increased cost to the federal government. In order to do that, there's going to need to be some funds. So if this initiative is passed by the voters, the January, July after that, everyone will start pitching in at 0.6% for employers, 0.06 .03 for employees. We have an operating fund basis for this group to meet and hire the consultants to do the analysis that they need. Because it's our money paying for it, and we're the stockholders, everything is subject to open meetings and transparency. Once they determine that the system is actuarially possible, they will put in for the waiver to the federal government. And also in the course of this time, probably like the exchange has had little subcommittees, work on getting prepared for an election so that elected members of the board can take over. And the idea is to divide the state into 7 geographic regions that are pretty much health service areas. And if you look at how our state is divided right now for like Medicaid regional care collaboratives, it would probably mimic that at some level. And then these regions, each of them would be able to elect 3 representatives to be on the trustee board of directors for the cooperative, which would have 21 people on it.
My concern is the bill has no conflict of interest clause in it. I'm concerned that this board of trustees are going to be the foxes guarding the henhouse. How can you assure people that won't happen?
Yeah, so I think that you could definitely say that for the 15 appointed people, because there's really, the criteria we put on the appointees is that they try to represent the diverse geographic, racial, ethnic diversity of the state. But once you get to the election, it's really up to the people to choose who they elect. So anyone can run. I mean, in a real democracy, you can't say only you can run or only you can run, and it's really up to the people to decide who they want to elect.
But who has the money to buy those elections? It's the special interest again.
Potentially. I guess I would hope that it would be an easy argument for other people to make on a more regional basis. And I don't know how many special interest people live in southeast Colorado, but I suppose enough.
Well, why not put into the bill conflict of interest, which will limit the special interest ability to be on that board?
You send that to us in writing. It's something, I don't know that it matters for the bill, like I said, because I don't think the bill will be passed. But I think it's an interesting concept to consider. I'd love to hear feedback from people like Common Cause and stuff. Because I know when you go into trying to say who can and can't do something, people start to get defensive about free speech and you know what I mean? It's more complex than you would think, but I think that's a legitimate concern and discussion. Now, we do put in that there need to be, that because this isn't a statewide voting election, that there are rules around elections in terms of transparency and who pays for them and what the limits and contributions are. That doesn't mean that somebody doesn't still have more name recognition because they were CEO of the hospital, whatever it might be. But certainly we do try to build in fair campaigns into the legislation. Once the waiver has been granted, the cooperative was sort of decide, okay, when do we want to get started? And at that point, the tax base would start to be coming in, the 6.66 and 3.33. And it would start basically with only the money that was collected while it was forming, and then be live day to day, sort of like Medicare was the first day it went live. It went live with nothing in the bank, and then built up its money as it came forward. What's put in there is that there can be no deductibles, that it has to cover the same range of services required by the Affordable Care Act, that there can be no co-payments for primary and preventative care, and that in order for a plan or system to implement co-payments, they need to get approval of the board of directors of the cooperative. And the basic idea would be that you would go on to some kind of system or go and sign up in a system, and you would either sign up for, I want to be Dr. Aguilar, whatever system she's in, or I want to be in the Kaiser system, however you chose to pick your provider.
What's the use case for having a copay? Why would you then allow for a provider to ask for copay?
You know, I think there are some high utilizers who are, copays can because there are people who abuse the system. They're 0.1%, I don't know what they are, maybe Judy or Vince know better, but it's not the majority of
Probably be
patients.
1 or 2% of the
Yeah.
people.
I mean, there's a
The
really-
common misconception is all these people are gonna abuse the system. And I
Right.
can tell you from working in ED at Denver Health for 32 years, it's a very small number.
Right. So the idea is you don't want to prevent them from having ways to discourage those folks who they have other ways of managing from overutilizing care. But I don't think it's something that.
If you've got a universal system, you know who the high utilizers are, then you knock on their door and get them the mental health they need for their issues.
Yeah,
Right?
I mean, that's gonna be the,
Personality too.
yeah, ideally, that's gonna be the incentive behind the provider who's managing their care at some level, right? Their goal is to do that, is to figure out who are these people, how do I stop them from going? But if they decide that what will work for this person is making them pay, then we don't wanna keep them from using that tool. So that would be the only situation in which I could see something like that happening. I guess the only other thing would be if, let's say this plan had lots of extra money and they decided they were gonna pay for LASIK for people. But they were gonna make people pay $100 for LASIK and they wanted to do that, that's above and beyond what's required. And if they wanted to do that, that might be something that was, I mean, I can't really say what people would come up with, but we didn't wanna forever prohibit it in case there were legitimate reasons in which the provider thought it could be utilized as a way of ensuring that the right people got the right care at the right cost.
Yeah, but what a lot of it is, I mean, when I look at what the insurance pays and what the, you know, the out-of-pocket for the person, it's clearly just the, you know, sorry, it's clearly just that the insurance company is not paying most of the bill. The majority of the bill today goes to the consumer, and it's getting more and more that way.
Right, so that's why this is different, because actually the person who's controlling your funds is your provider, and the more care that you need, because you're not getting the care that you need, comes out of his pocket. So the incentives are, in other words, let's say you have knee replacement surgery and your knee isn't getting better. It's in your provider's best interest to give you the therapy that you need for your knee to get better so that you can stop coming into the clinic. Because all that money is aligned, it isn't that they get more money because you don't go to the doctor, because you're still gonna go to the ER because you're having pain, you're still gonna come to his office because you can't walk right. So all the incentives financially are aligned. It's a different model in that regard.
So are you talking about bundled charges, or bundled reimbursement?
We're talking about providers, sort of, I call it managed care on steroids. There's managed care with two things in it that managed care doesn't have right now. One is risk-adjusted payment, and the second thing is a safety valve. There is a reinsurance pool available because some people just won't be able to fit into that model because of the nature of their diseases. And so there needs to be another way in which to give the money needed to take care of those folks. But in general, what you want to do is incentivize the provider to find the best way to keep that person healthy. So the idea is that you not set any delivery model. You just say, these are the health metrics you need to meet. Everybody needs to be offered immunizations in a timely fashion, and your numbers need to be near what the average are for the state. Blood pressure is expected to be measured and under control, at least at the same level as the rest of the state. And if you're making your quality metrics, and those quality metrics ideally would be based on evidence-based medicine, because if you look at what's really proven to make a difference, it's not as big as you would think, then you're allowed to innovate in how you deliver your care. So in the ideal system, what I'd like to see is that there are providers who specialize in different things. Perhaps I've learned a good way to help diabetics control their disease, and I have in my office more dietitians, more nurses, more people who do home visits, whatever it might be. When I design my practice again around the population I want to care for, there are a lot of people who always ask me about alternative health care, acupuncture, massage, whatever. And I think there are patients for whom that is a cost saver. I don't think it's fair to say everybody needs as much of that as well. There are patients, particularly who have chronic pain, who maybe a provider wants to specialize in chronic pain and pay to have an acupuncturist in their office, or pay to have a chiropractor, massage therapist, or whatever they want. So we want the innovation to be designed around the population that you're serving and figuring out how you best care for the people for whom you're working with them in partnership to keep them healthy. The other idea is that hopefully this will then incentivize people really doing more work on prevention in terms of healthy eating, healthy living, and things like that, keeping your mind active. So the delivery models are very different, but basically, the better you keep, healthier you keep people, the less it costs you. Now, the payroll tax at the 6 2/3% to the employers includes the medical portion only of workers' comp. It can't include the risk portion of workers' comp because you still need them to have an incentive to keep their employees healthy and to pay the consequence for putting employees in dangerous positions from which they suffer long-term consequences. But one of the things we definitely wanted to do was have someone be able to always see the same group of providers and not have to switch just because suddenly that insurance isn't working. At 6 2/3%, it would be a drop of almost 6% from what a employer pays right now for medical workers' comp and private health insurance. The amount to the employee would be 3 1/3%, and for most employees that's significantly lower. It is capped at $350,000 income for an individual, $450,000 for a family. So any income you make over that is not taxed at this rate. It's yours for free, but on that first $350,000, $450,000, you would pay this tax, this premium tax. There would, of course, need to be audits. The plan would apply to be a Medicare Advantage plan. If it was not accepted, then it would be a secondary insurance to Medicare for people who lived in our state. And this would also involve applying for a Medicaid waiver so that Medicaid patients are in the exact same system that everybody else is in. But the long-term care funds would be held separately, and only people who qualify for Medicaid long-term care would get Medicaid long-term care. That's it. Yes, ma'am.
When you were mentioning, I mean, about the capping, will that increase as, you know, the cost of living and the value of the dollar goes up in the plan that's written in?
Right.
Because, you know,
Yeah,
used to be a
and,
fortune.
I'm embarrassed that I don't know the number right here, but there is a number written into the initiative
Okay.
by which it is allowed to increase every year. It's tied to CPI somehow, but
Yeah,
I'm not a good finance person.
Okay.
And then if, though, you got to the point where you couldn't afford everything you needed, with that, you could always take it back to the members for a vote to say, look, we can't afford to give everybody A, B, or C, but if we were to increase your rate by 0.5%, we could do that. Will you vote to do that for 0.5%? And they could vote to increase it above and beyond what's statutorily allowed.
Does this cover dental as well?
So the first year, it's a $250 dental benefit with the goal that it goes to a $1,000 a year dental benefit.
Okay, so this covers, because that's a real issue with health.
It is for a lot of people. Right. Ellen?
You say in your proposal, I believe, that you have a choice of your primary care provider. Nothing is said about whether you have a choice of the specialist or a choice of the hospital.
Right. So here's what I would expect would happen. So if I still worked for Denver Health and you picked me, you'd still be part of the Denver Health system. The question would be whether I work with Denver Health to say I want us to have a way for people to see whoever they want. And we might do it in a different, this is where again co-payments might come in. We might say if you stay within our system, it doesn't cost you more, but if you want to see somebody else, we'll let you do that, but you have a higher co-insurance to do that. I think it's harder to guarantee specialists because they're each going to contract in the way they want to contract. And I think what would be interesting will be whether you can decrease demand for them by having better coordinated primary care. Nathan?
So on the provider contracting, it says that the Colorado Care shall contract with providers. So concern there is that there's no cost containment if they're a specialist or if they're, let's pick something like pediatric dentistry. I don't think I've even found a pediatric dentist that accepts any dental insurance because they're so specialized and they can command whatever they came directly from the patient. So what's to prevent specialists or whatnot from, I mean, in any other universal healthcare system, they set payment rates globally, universally. They adjust for things like geography or whatever, but in this case, there's no way to bring that cost down.
Yeah, so I think, and as you know, there's been a move, which I don't necessarily think is good for patients, towards more and more employed physicians. So, for example, St. Anthony's pays for their neurosurgeons and cardiologists now. And so I think sometimes that will be tied to the system. And it's one of the unfortunate things happening in medicine is doctors have fewer and fewer choices about how they can practice. So I can't speak to dentists or pediatric dentists. I can say that unfortunately I think most providers will be incentivized to be part of this plan, because what you find is that patients want to go where their plan is pays for and aren't very often willing to pay out of pocket. Again, there are some people who can afford to do that, who I anticipate would still do that, but that's not enough to employ all the specialists that exist.
Section 11.1 of your bill you have here says Colorado Care is a secondary payer subjugation rights. It says Colorado Care serves as a secondary payer to any health insurance plan in which a beneficiary is enrolled that may be responsible for the beneficiary's health care expenses. So what's to prohibit United Healthcare from doing what they do now with Medicare Advantage, of saying you can contract for your insurance with us, we will charge you no premiums, and then going back to the cooperative to get their premiums. And so you now have the private health insurance controlling the patient and with narrower and narrower provider networks and choices.
So there will be two possibilities. One is that the cooperative is separate from Medicare because we get no waivers. The second is that the cooperative is a Medicare Advantage plan itself.
No, this isn't for Medicare, this is for other people's insurance.
Oh, okay, so that was specifically put in there for ERISA plans. So an ERISA plan could still choose to pay for you to have private United insurance. And whatever your United doesn't pay for, the cooperative would. So my daughter has both Kaiser and Medicaid because she's under 26. So Kaiser pays the first part of her bills, and then Medicaid pays anything that Kaiser doesn't pay for. So that's what this would be. So this would be United would be getting the money from the federal government, like they do now. They would pay the first part of your bills, and the cooperative would be your secondary insurance, and that's what you get for the fact that you're paying 3.5% into the system.
What about non-ERISA patients, just the person who now has private insurance and says, I want to keep it?
They have to buy it above and beyond paying into the system. It's like public and private
Well,
school.
what's to stop the private insurance company from saying, you can continue with us, you don't have to pay any premiums, and then going to the cooperative to collect the premiums, or whatever the cost is of the care?
So the cooperative won't pay premiums, and the cooperative will only pay directly to providers providing the services.
Okay, so then they just submit bills for every service they provide. They can do that. So now you're directly subsidizing.
But they wouldn't be submitting it to the cooperative, they'd be submitting it to the primary care provider who has taken on that patient's life. The cooperative itself does not own patients.
Well, I think
They could own the primary care provider. They are
The
now
cooperative
providing
does. Well,
ACOs.
yeah, then they're billing themselves. They have a pool of money from which to work with.
Well, I think the more likely scenario is that a for-profit insurance company buys up a provider network and they
Exactly.
maintain
That's the problem.
as for-profit. So that's an inherent conflict of interest, systemic, because they're in control and they could be running it. I mean, part of the problem with some of the
That's why you can't have co-payments without having improvement from the central
with
thing.
the MA plans, they run it like an HMO, so they act as gatekeepers
Right.
and keep people out of seeing
Right,
specialists.
and so how long do you think people would stay with their plan? If they knew that these guys across the street aren't doing that? Because it's the same cost to them.
So
I mean, the
you
advantage
know
they have
how-
now is that they can be part of one of those HMOs and not have to pay anything. But now they can be part of the regular system and not have to pay anything. So why would they be part of a coercive
Well, no, I'm
for-profit
saying in the
HMO.
regular system where you,
Instead of-
the insurance company is now out of the insurance game, but now they're in the provider game. Because we've seen that they're buying up provider practices. So now, United Healthcare is an ACO with, some limited provider network, and they're doing all the same games. There's
Right.
no,
And so the person votes with their feet, because there's not a financial disincentive. Right now, there's a financial disincentive to not be in United. There are things that they provide for you that nobody else will provide for you. That's not gonna exist anymore, everybody will have that, so you can get it here and be treated like crap, or you can get it here and be treated like everybody else.
I think what I'm hearing is that the real problem is now that all the providers are gonna be owned by these big for-profit insurance companies. So if you want to liberate them, as it were, and I kind of had this kind of situation when the group I was with was owned by a physician management company, which is how we were all shut down and lost everything with the practices, because it was either you buy yourself back at an exorbitant amount of money, or they shut you down. So maybe what needs to be done, because of the way healthcare is
Has evolved.
evolving, is that there has to be something in the bill, or that
That
you get a
absolves them from
liberation
those
clause,
contracts.
that if you are owned by these
Could you send that to me, Ryan, that's a good idea.
yes, these vultures,
Right.
then they must release the clause and let you go at a reasonable cost, like a small percentage of what may have been
I don't
paid
even know
in.
if they need it.
Well, or just to let go of them,
Yeah.
because when you're owned, and who knows what kind of contracts, they may have 10-year contracts, or,
Yeah.
you know, it's like indentured servitude.
It is.
And so, and that's
And
where
that
we're
would be-
headed.
I would agree with you that we need to do
Yeah.
that, I hadn't thought of that.
Well,
Thank you.
Yeah, so,
Could
I-
you do
Just,
what? Could you rephrase that?
So right now, there are providers who have contracts with, hospitals, say. Remember I said how the hospitals pays the neurosurgeons and cardiologists?
or insurance companies now are
Um,
buying them up too.
Oh, really?
Yeah.
So they could say that, she's saying what we would need to do is have in there that all those contracts are void when it becomes a cooperative.
Right.
Because right now, Nathan's situation could happen, right? I owe you, and I have all this money, but I get to set the rules
Yeah,
on how you get it.
it's a real dirty deal.
And what we really want to do is turn this game, that it's the provider who has control of the funds and contracts with the administrator to advise them on how they should administrate the plan, but they make the decisions. And interestingly, that's the model in which Rocky Mountain Health Plan was built. It was a working relationship between doctors and people who understood the insurance business. But the doctors sort of worked out what are the rules, how we're gonna run our business.
Well, why not fix the whole problem by saying that all hospitals have to become not-for-profit and have global-based budgeting? That's the only way you're gonna control these huge, crazy hospital costs.
Yeah.
And say that no private insurance company can provide the basic insurance. The cooperative will do that. And because they're reaping huge profits and gaming the system and screwing people over.
Yeah, and you know,
I understand
interesting, because a
politically it's
number
hard.
of years ago, Vince, I would have said, boy, that'll make it an even bigger fight, but I don't believe that anymore. And so I think that's a good point. I think when we're going forward with the initiative that we're collecting signatures for, I think those are things we need to reconsider.
not just hospitals,
Yeah.
ACOs as well, should be on.
Yeah.
Yeah, I think you just
Yeah.
make it clear up front, because
That
that's
everything's
where the
up
real
front.
cost savings are.
I would agree, I would agree. And like I said, I think before I had
Drug companies too.
well, the thing with the drug companies is they're not regulated by the state. The best we can do, and we say it in the thing, is that we can, as a state, negotiate for prices.
Yeah.
And then interestingly, one of the things I found out is that as you apply for waivers, one of the things you need to do is get waivers from the federal government for how you can negotiate for drug prices, because they have them all tied up in games right now between who can get Medicaid prices, who can get corrections prices.
Really?
Yes.
Oh,
And in fact, I said, why don't we go for the whole thing and just say that we can buy our drugs overseas? Because I think that'd be awesome.
That's what we should do.
Yeah.
I want to go back to the dental just for a minute. I could see how a $1,000 benefit could encourage people to go to the dentist, so that might be a good thing. But for those of us who've ever had any dental work done, $1,000 really isn't very much money compared to what we're
Not
going to
anymore.
spend.
Mhm.
And so I just wanted to
Yeah.
recognize that. I think that's
Yeah.
one crown would wipe out the benefit.
I hope not, but, I think, the reasoning here is that we were trying to be fiscally conservative in what we promised. We didn't want to promise things that we didn't think we would have the funds to do, which is why after we heard about what happened with Vermont, we went back, we got the number, and we sent them back to the economists, and we said, these are our real numbers. And then, does this really work? How much do we need? And we sent that back to our, economic analysis team and said, this is the number we need to make, what's the number we need to tax you at? Because the one thing I did not put in here is this is based on current level spending. So if any of those ideas around cost containment efforts are effective, and notice I said it if, there should be more money than we're seeing right now.
I wasn't
But
trying
if
to
it-
argue
Oh,
against
no,
it, just
but I'm just
recognize
saying,
that there is a hole
yeah,
there.
I mean, of course, the physician part of me says, if this really is a barrier for them, I would hope there were a way to make this happen. But I think we wanted to be really cautious up front to not promise things that were not accounted for in the budget.
And I personally just would like it, because every time I've had dental insurance, I've literally never used it, because the dentist, either one, didn't take it, or it was such a small amount of money compared to what I was spending, it was pretty much not worth the effort, believe it or not.
Not worth the premium.
Yeah, not worth the
I was
premium.
just curious about mental health and where that falls and if that will be covered equally, if it will be acknowledged or.
Yeah. So it is talked about in there, and I should
integrated.
tell you, three of the people who I work with on this effort are in the mental health field.
Okay.
And so it's well realized. And one of the interesting things, and Vince, I don't know how much you've heard about this, but Denver Health got one of those grants to do like a hot spotter program, to pick the really costly people and put in an intensive care plan for them and try to decrease their costs. And what was quickly identified was the number one need was mental health and substance abuse treatment. And so I think that as you start really focusing on who are the cost drivers in medicine, you'll see how much we shot ourselves in our own foot by cutting back our mental health and substance abuse care. So I think that gets tied into this whole thing about value-based medicine and controlling costs. So we need a lot more people in school to do that.
How is Medicare? I mean, would somebody on Medicare have to pay this 3.5% or whatever?
So it depends on what kind of income they have. So certain retirement and pensions are excluded. But there are some people on Medicare who get a lot of capital gains, and those would be included.
So it would be on the capital gain?
Yeah.
Okay.
Yeah, and I think it lists in there which ones are excluded.
You would
But
be
I
allowed a certain amount of capital gain, but not beyond that, is it?
That's a 10% tax, right?
think it's the full 10, because you don't have an employer paying part of it.
Yeah.
Since I'm not the only gray hair in the room, do I understand correctly that assets would not be means tested for long-term care?
No, assets, they don't keep you from getting Medicaid long-term care.
So you
But-
don't have to spend down like
You don't have to
used
spend down.
He's asking about the cooperative long-term care.
Oh,
coverage.
cooperative long-term care will be the same as Medicaid. It's basically what
Same
you
as
need Medicaid
Medicaid?
long-term care.
So you'd have to spend down your assets.
So you don't have to spend down, there are different criteria. So it depends, you can have a house, you can have,
rental property?
no,
No.
you can have, and I don't know that you sell those up front or the state gets them when you die.
Or when you die, so
It's
it
when you
really
die.
doesn't matter.
Yeah.
Yeah.
But you would still.
But that would still be the same.
And you don't need the money when you're dead, so it's okay.
No, it was because really long-term care is gonna be a problem for everyone. And again, we wanted to sell something that was real. And if we went out there saying that we were somehow gonna cover long-term care, that would be foolish. That would show that you don't really understand healthcare, because that's a much bigger problem than our current acute care medical system can deal with. So all we are going to do is hold harmless what benefits you would naturally get under the federal Medicaid program for long-term care.
Okay, and the second part would be that in addition to hospitals being nonprofit, having a global budget, certainly long-term care facilities would have to be treated pretty much like hospitals rather than for-profit, long-term.
You know, there's been, this horrible thing that's happened, which is that hospice became for-profit a few years ago. And it's amazing, it is just amazing to me how for-profit hospices have figured out how to get the patients who like mostly have cancer and are gonna die quick. I mean, and so they had all these practices that were somewhat, that were basically making them cost Medicare a lot more, and so like so often happens, Medicare passes all these rules that then end up making it harder for these not-for-profit hospices. And so just recently, there's this type of insurance that we have in our state, that's the PACE program for all-inclusive care for the elderly. And they basically get a monthly fee to cover all your long-term and short-term care. You see those little Innovage buses running around? That's the PACE program. So they put in a bill this year to say that our Medicaid department should apply to allow them to be for-profit. And I brought up the hospice example to say we shouldn't do this because look what's happened to hospice. So apparently it would have to be a Medicaid waiver, and so far Medicaid has resisted those waivers, but I don't know if the bill will pass or not. We'll see what happens.
I'm curious about Social Security. Medicare will be taxed at a certain level, will it? And will Social Security also be taxed? No.
No, so those retirement funds are not touched. It's other income. So people who are very wealthy and have capital gains, they will be taxed. Yes, sir.
In the Colorado Health Insurance Exchange, and hopefully Nathan can correct me if I'm wrong, I think last year, 40% of the new signups went to Colorado Health Law, and 40% remained with Kaiser, and then Equate's in there, somehow the Denver Health Plan. Elevate, sorry. And I thought as we were buying insurance that there were really, because it was all very confusing to me, that there were really, what helped me kind of focus was I was really trying to do two things. One was to provide some kind of stop loss to what we would incur. And the second was have a way to buy health care. And there's two plans in there that are different than every other plan, and I think that's Kaiser and Elevate, where they actually provide health care as well as health insurance. And I just wondered, you didn't mention Elevate, since you're on the board of directors, I guess, somehow. Is that working out, and do you see a trend where we buy a plan that provides health care?
What I think Elevate has struggled because a lot of the people who are relatively living in poverty who are already seeing Denver Health are the people who bought Elevate. So they got risk adjusted wise probably a sicker population. And so their rates went up a lot this year. And so I think it still suffers from the I'm not poor, I don't want to go to Denver Health. So people who are healthier or wealthier don't necessarily buy it. And then it suffered from the I'm poor and sick and I've been getting my care from Denver Health for a long time, so I want to stay there. So they got a sicker population. And so it didn't work out quite so well for Denver Health, but they're still trying. And they're really trying to get more interest in city employees and trying to figure out how they can make a deal that city employees will choose their insurance plan. But there's some natural segregation that happens, as you know, amongst people.
Yeah.
So with this other distinction though, that was important to us was, like I may not like Kaiser, but at least I know where to go to get care. And when I called Colorado Health Off, what put me off, no, this is the Colorado, this is the other, it's just another insurance company, it's not the same thing.
That's why we became Colorado Care.
But when I called them to try to find out, I got a customer service person in Texas. And when we looked at the providers that we could actually use, it was very, they didn't seem to be the ones we wanted to use. And so I with Cooperate Colorado, with your co-op, will we know more about where we're actually gonna go to get care as opposed to just wandering around Denver looking for health care?
So you're actually supposed to pick it based on who you want your primary care provider to be. And then when you look at your primary care provider, it should tell you who's working with them. So who's part of their group that's working together to take care of your care. You know, to tell you, I have a couple people who take care of my daughter who don't work 30 hours a week, and they bought insurance through the exchange. And I was impressed by a couple of things in the Colorado Health App Plan, and they both got out to the Health App Plan. One was that if you do the questionnaire and take the biologic screen that's recommended for your age and visit your doctor, they give you a credit card for $900 worth of health care services, whatever you want to do. And the other is that in addition to paying for preventive care, they give you 2 free primary care visits. And I think the idea there is that when you're sick, to hopefully see if that will work to get you to go see your primary care doctor instead of going to urgent care or emergency room care. So I'll be curious to see how that works. I think it's a great idea. I know Jack Westfall, he actually supports my bill individually. He can't get Colorado Health App to support it, but he said that the other thing they're doing is they're giving people with high blood pressure home blood pressure cuffs and having them enter on a computer system to try and manage their blood pressure. So it's sort of fun to see what a doctor does, you know, with the healthcare system.
Unfortunately, the things like you mentioned was when you're looking at the Colorado Exchange online, it's hard to, I don't recall seeing that. I mean,
Yeah.
you know.
We went to meet with a broker because I was looking online, and to be honest, I was sort of confused about what the money limits meant with co-insurance versus deductible versus, my copay is clear, but co-insurance and deductible are sort of confusing to me.
Have you had discussions with private insurers about whether they would support or oppose your proposed bill? Where do they stand on
They
this?
oppose it. Yeah, the
They
Colorado
oppose it.
Association of Health Plans.
So if they oppose it, then why not go all out and get rid of them? I mean, they're gonna oppose it anyway. I mean, most of the people on your side.
You know, that's true. I think you're raising 2 good points that I was somehow naively thinking before would save us some money, and in retrospect, they're not gonna save us any
Well,
money.
or politically,
Right.
maybe not be so
Right.
hard to get it through, but
Right.
they're gonna oppose you anyway.
Right, and as are the hospitals.
And the
And,
hospital association.
You know, and what's really too bad is I think there is a role for the skills that some of the insurers have. You certainly don't need all those paper pushers in the office, but there are skills that some of them have in terms of figuring out. As a doctor, I wouldn't know, like, is it more cost effective for me to have a social worker or a nurse, and, you know, what are the things I can pay for them to do? I mean, there are management things. You need to be able to sit down with somebody and figure out, how do you do this, what are the costs, how do you make this work? So I think as a partnership, it would be great, but you're right, as an individual, they don't have much value. As a corporation, they don't have much value.
2 questions, not related. Would you see a provider under the system being part of multiple ACOs?
I think certainly for specialty providers.
So in that case, you don't eliminate the paper pushers, because then they're still having to figure out how much they get from this one and that one.
I mean, what we're envisioning is sort of the credit card model, right? It goes into a machine that says, I saw this person for that much, and then the amount is transferred. The state, the Medicaid and Medicare have so automatized payment that it's not a problem. The paper pusher problem is, did you get permission to do this? How much does it cost you to do this on your plan versus the plan this guy over here has? That's where the complexity comes in. If it's a flat, you get this much, no matter who you see, no matter where they are, then that's a little bit easier to deal with.
Okay, so the other question I had, I kind of want to talk about this in the Colorado Care model, but also jump back to what you were saying before about Tier 4. So pharmacy benefits, how would they be covered? That's one of the expensive parts of the system today, and you have tiers.
I think that's something the
fully-
board of directors needs to determine, because obviously, if what we're really focused on is outcomes, certainly for diseases like what your son has, how can there be any question, right? It needs to be paid for.
Right, but if there's, there's a lot of people who can't afford a $10 copay for a basic
Right.
statin or whatever, right?
Right.
So that's gonna prevent them from getting the care they need. Would there be
And
full coverage of
I would hope
benefits?
so.
And if
I mean,
not,
that's what I would anticipate that the providers would determine. One of the things that always drove me nuts is that, and any of you have been providers, is that we always make these rules that are the same for everybody, and everybody's not the same. You know what I mean? So the risk for me not giving this to this young woman here whose cholesterol is 240 because she really wants it down, versus the risk of me not giving it to this gentleman here who's had a heart attack are significantly different. But if they're both signed up for the same plan right now, they get the same benefit no matter what. This is more personalized to the person,
So
their disease.
assuming
what the
there is
provider
some
thinks.
copay, or even, forget the pharmacy, there's a provision where there can be copays in situations, right? Is there,
So that has to
is
go
there
through-
also, is there still an allowance, is there still a limit on out-of-pocket maximums?
So that, the co-payment part has to be approved by the cooperative. So it has to be a model that's approved right up front, you're not allowed to have any.
But let's say for my son's medications, that there's, he's in a tier and maybe it's $100 copay or whatever,
Yeah.
we could be paying that every time without a maximum.
Yeah, no, right now you're not allowed to have any co-payments. So if somebody wants to propose a co-payment structure, they have to propose it upfront.
So jumping back to not this scenario, just real life tier 4, you mentioned the bulletin the DOI issued about capping it because it's discriminatory, capping it at 1/12 of the out-of-pocket max. And I wasn't clear what you is there a bill that's being pushed, or you're trying to
No,
change?
we're gonna, so Marguerite, said, so two things. Okay, this is Vegas now for a second. So the insurers are not allowed to get together and bargain for drug prices. The Division of Insurance could bring them together and propose that. So that's one thing that we can. It's because of antitrust laws.
In terms of how they're priced tier 4?
Well, no, in terms of getting drugs for people in our state here.
Okay.
So that's one thing that Margaret wants to explore, is pulling the insurers together, seeing if there's interest in having, and then Sue Bird with Pickpuff has talked about whether we can allow people and allow insurers into the negotiations that we get for our Department of Corrections. So we're looking at other ways to deal with this where we're not.
Well, that doesn't change what they charge for tier 4 if they're doing.
No, this would be part and parcel of the deal, right? We're doing this in order to protect patients. So how do we get patients drugs at a reasonable price without having insurers have to pay whatever the pharmacy companies want them to pay?
So how are pharmacists gonna be connected in this?
So pharmacy companies will hate this because of.
The pharmacy that you go to, they would hate it.
Oh, the pharmacy, I don't know that it'll be any more complex than what they deal with right now. It's just a matter of how do we get to a point of being allowed to do at some level bulk negotiation, even if it's just for specialty drugs. So one of the good things that's happened with this whole specialty drug discussion is that everybody's more interested in how can we get cheaper drug prices in our state for our people. In fact, Senator Lambert during a joint budget committee hearing, because he heard about, I think it was the hemophilia drug, and it's some outrageous percentage of Medicaid's budget that goes just for that drug. I think it's like 10 or 20%, it's something crazy.
No kidding.
No kidding. Because it's made from some special mice in China or something. And Senator Lambert said, can't we grow those mice here in Colorado?
Well, even the one that comes from plasma is equally as expensive. So
Yeah, and so I think what's interesting is this Medicaid expansion has brought all these things that we've been dealing with for years more to the forefront at the state level in the Joint Budget Committee, because they're seeing directly the impact on the state budget of these drugs, hepatitis C drugs, hemophilia drugs, what our policies are around that. And so, in fact, Senator Lambert even said, maybe we should get a generic manufacturing company to relocate to our state. Now, isn't that interesting? Would you ever thought a die-hard Republican from Colorado Springs would suggest that we do that? There's hope.
But
It has to get bad enough, doesn't it?
Yeah,
Well,
no,
in that
oh yeah,
case,
not
the
for that, he
cost-
was just talking about all the other drugs.
The biosimilars, the cost is the same because they have to go through they're not identical. They have to go through
Is there anything in your bill that would establish a statewide formulary? Because that's one of the ways private insurance companies control costs, and it's
Right.
an obvious way to do it. And then negotiate pricing on all drugs.
Yeah, so it does establish that it would be statewide bulk purchasing of all drugs. It doesn't go into the details saying there'll be a statewide formulary,
But
and I'll
there's
tell
gotta
you
be a
that's because
formulary.
when you talk about formularies, a lot of people panic.
Well,
Yeah,
but
and they leave
Just
things
the
out
mental
for
health.
some people,
Right.
you know.
Right. So, but the concept is there.
But the private insurance companies are doing that now. People,
don't understand
people
that.
could, they
Yeah.
don't understand that.
Yeah.
They
And
are
that's
doing
one
it.
way they're keeping the sick people out of their panels,
Yeah.
is you're not putting the drugs on their formulary that they need.
Yeah.
That's,
And that's part of why I avoided talking about a statewide formulary. I think any drug you get in our state, we should as a state negotiate for.
Yeah.
But to start picking winners and losers in drugs,
well, every other country does that. Canada does it, Great Britain does it, and it works very well.
Yeah, they do. But then, you know,
it's one of
then
those
there are new
sensitive
things
things
that come out.
consumers.
And it's
it
evidence-based.
takes a year or so to get it on the formulary, and so that's a difficult thing to do.
Just a comment here, you know, we're talking, speaking to the fire, of course, and I think the big deal is really to get something passed and then it can be tweaked, fixed, put in whatever else we need, because a lot of the stuff that's being brought up, people are clueless about so much of this formula, and they immediately go back to the PR of all the negative propaganda
Well,
of
the death panels
you know,
are
that
rationing.
we're going to be taken over, in the past it was communist, now it's going to be that ISIS that is going to take over our healthcare system.
And we have
So,
no
you
formula,
know, I think we
so
need,
much
you know, whatever it is, there's always a scare.
But imagine that same conversation when you say, look, if we were willing to go to a formulary like this, we could increase your dental benefit to $1,500. So let's put it to a vote, right?
We could do that, as long as they had a choice.
Right.
Yeah.
So that's why I'm saying to do it up front is really
Yeah.
hard, because you
No.
really don't know.
No, I'm agreeing with you,
Yeah, yeah.
because it's first like get the
But
big
I do
picture.
think it is something that potentially could be looked at in the
Absolutely.
future.
Absolutely.
But you need to sort of first, and the prices we put in were based on what we're paying and getting now. Because we just wanted to assume that people didn't notice a change immediately.
So let's imagine the best possible scenario, and this, things get passed as you would like, okay? So then what do you do with all these exchanges, and does that sort of disappear?
So let's say we got it on the ballot and it passed in November. The soonest you could possibly see anything change would be January 2017.
Right, yeah,
Because it would take at least a year
yes.
to get up, apply for the waivers, and figure out the system. Realistically, 2 years.
But once this, if something like this became a reality, it would basically make the exchanges obsolete, it would seem.
So it would make our Connect for Health exchange, I wouldn't say as much obsolete as have a different purpose. Because you still need a technological system where people who are technologically savvy can go and look and see who are the providers, what are their
Right.
ratings, what do other
But they
people
wouldn't be
say about
selling under
them.
insurance.
But they wouldn't be selling insurance.
Okay.
They would be selling information about if you get this primary care provider, this is the network they're with, these are the hospitals they work with. Their technology would be doing those things. And potentially that would be the body that the cooperative used to sort of help coordinate the other things that need to be done. I know we didn't really talk about it, but sort of to Vince's question, we have too many hospitals, and either we don't fund them all or upfront, and we're honest about that, or we let them fold. We need to be sure we keep some working. We need to be sure we can sustain trauma services throughout the state. And then we also need to have that mechanism designed for what happens if Dr. Aguilar gets 50 patients with hemophilia. There's no way she can make it on that November one.
Well, another thing you might bring up, you know, because we're having such a problem with rentals, that chiropractic hospital over near the old university, you know, that made it into these beautiful condos. So a lot of these really lovely hospital buildings could be converted into affordable housing.
You know, that
So Randy would really like it.
That came up yesterday, let me tell you the best part, they're all accessible. It'd be for the disabled and seniors. So maybe what we sell this as is
This is a
disabled housing bill. It's a little afternoon and now you have to get ready to get going, so I want to thank you all for your good questions. Vince, you know, it's interesting to see how time has changed my perspective on some of those things. I think it's time to just take those bulls by the balls and deal with them.
Yeah, go for it, Irene.
Because it's
like
clear,
that.
it's not gonna make,
Bulls by the balls.
it's not gonna make a difference.
bumper
minds and hearts
stickers,
will
new
follow.
bumper stickers. I can see it now. Synopsis and give you these handouts. Okay, so by default, I am back in charge of the legislative committee. I hope you all are computer savvy enough to turn on your computer and look at the website. There's a place where it says on the website, a drop down that says get involved. The very bottom of that is this LegCom. So on it, this is what you'll see when you go to LegCom. I didn't make a bunch of copies because I'm into trees and don't like to see them used for paper. So there's an extra one. So it'll print up like this. I change it at least weekly, if not twice weekly, to follow the bills, many of which I will say are Senator Aguilar's bills that have passed and the governor has already signed. It's not what we, they're little Band-Aids. We're stopping the bleeding somewhat by these bills. As we can see, there's lots more to do. But the other thing that's a wonderful thing to have is I subscribe every year to the League of Women Voters legislative letter. So I made a copy of the most recent one, and there are 15 copies here, 3 pages, not just healthcare, behavioral health, which we have included in some of our bills, and children's issues, education, equal opportunity. There's a whole bunch on healthcare right in here. And actually, there's overlap, because some of the stuff in criminal justice deals with mental health and deals with, and then a lot of the behavioral health issues, the children's issues. I mean, let's face it, it's all about the economy, isn't it? And, a lot of the poverty that leads to the downhill rolling of lots of people that ends up with being bad health and dying road. So please feel free to read these. Eleanor?
I like that one.
Oh, yeah. Oh, I thought you wanted to make a comment. But look at the website, because I am really trying to keep up with the bill. Some of them move through super fast, like one by, you mentioned that Senator Cavallas had, like, I think it's already ready to be signed, so anyway, good deal. Thank you, everybody.
Thank you.
Okay, yeah, I have 15.
Healthcare for All Colorado will be having our annual meeting sometime in June. We don't have a flyer out yet, but we could be looking for that in an email. Also, if you didn't register, we have 2 registration sheets at the back. We'd love to have your information, if you change your email, phone numbers, addresses, or if you don't have your contact, we'd like to have your contact information. And currently, I am the House District 9 captain, and we're having a tequila mixer on May the 16th, if anyone's interested in attending that. We will be honoring our city councilwoman, Peggy Lehman, who's going to be completing her term at the end of July. So we'll be honoring her, and we'll have some other legislators there to give us legislative updates. So, thank you. Eleanor?
Denver Chapter meeting.
Well, I don't have our speaker set yet, so it's probably the second Saturday.
Thing anyway for people to look at as I subscribe to it.
Okay. And thank you for being here.